Welcome to HealthCast. I'm your host, Adam Patterson. Today we're joined by Dr. Gil Alterovitz, who is the first ever director of the newly created Veterans Affairs National Artificial Intelligence Institute, or the NAII. The NAII represents the forefront of VA's medical and genomics research, where the agency is mobilizing its significant quantities of medical information and in-house expertise to advance American healthcare as a whole. Since its founding in the latter half of 2019, the department has applied artificial intelligence and complex data analytics towards researching conditions ranging from traumatic brain injury to kidney disease, with a core focus on improving care and diagnostics as an outcome. Most recently, the NAII has been a key player in supporting the federal government's response to the COVID-19 pandemic and providing caregivers with a deeper understanding as to the nature of the novel coronavirus. Dr. Alterovitz's expertise has been instrumental in guiding the NAII since its founding, especially in using his significant background in genomics to set the department's focus and direct its growing scope of research. Dr. Alterovitz, great to have you on the program.
Well, thanks for having me, and I'm happy to be here.
So as kind of an overview question and as some background for our audience, what have been your major research interests in artificial intelligence and genomics broadly over the course of your career?
When I first started thinking about artificial intelligence, I was working on a PhD, and we were thinking about how do you integrate protein, genomic, and other information, and AI. At that point was, doing this approach called Bayesian networks and looking at probabilities and how you can find relationships between different proteins and so forth to tell you more about human disease. Now, at the VA, we're, really at an era where you have a lot of different information where you can really make a difference in actual care. Back then it was research. I wouldn't say it's research for research's sake necessarily, but it was more, research to define new ground that then could be potentially applied, in some settings. But now it's really, not only developing those new AI methods, but also leveraging them right as you're developing them and applying them, and you get to see how it really can make a difference. So that's really, I think, one of the things that we've seen. And so right now, a lot of the applications are in clinical type of data. You may have information, it may not come from the medical record. It may come from devices, wearables and other things. It may come from, we have one work, it was involved actually a polling data, where you get to learn about health and well-being, by asking people about things. And it ended up, it actually was related to some polling data. So I think there's a lot of different ways that you can now really make a difference because the data is there to really help in serving the mission.
Yeah, and it sounds like there's been a lot of advances, broadly speaking, over the past 5 years in general artificial intelligence research and its applicability to medical care and health science. Which brings me to my next question. The National Artificial Intelligence Institute, if memory serves, was founded in 2019. It's a relatively recent creation. So as a broader interview, what is the NAII's core mission?
Right, and exactly. It was founded around the time of the Veterans and Family Month, which is it's a national month of November 2019. And what the National Artificial Intelligence Institute at the VA really focuses on is on developing those AI capabilities, using and leveraging research and development to help support the veterans, their families, survivors, and caregivers. And so it does that by a couple of different ways. It looks at what are there potential new partnerships? Are there new things that we can pilot? Are there new practices or processes that can be changed in the system? Are there new policies that we could influence around AI? And all these come together to really build that work around artificial intelligence, working across different offices and interacting with the different medical centers across the country to make sure that we can serve all of those that are involved.
Yeah, and it sounds like a lot of the increasing digitization across VA and a lot of the advances in kind of like genomics and health informatics has really played into that as well, which kind of brings me to my next question, which is what were some of the foundational or earliest research projects that you helped oversee at the NAII?
Right. So there have been a number of exciting projects that have been going on. So let me tell you about, list a few of them just to start. So we've, recently, for example, with COVID, there was a COVID-19 120-day mortality morbidity model that was developed. And that's been some interesting work that actually then led to other work. So what we found, for example, in COVID-19 is that, essentially there were no models, right? Because it was just something totally new. And so research and development is really critical for developing that. And then how do you kind of get that into practice quickly, right? Because you need it to move quickly, right? And so looking at new processes, new ways that things like that could be piloted to get quick clinician feedback. That led us to another project, which is kind of the continuing project of this now also, which is the AI to go framework. So the idea that you could look at different types of diseases and have the work of different researchers who are building different types of models, get quick feedback and iterate with clinicians and others as they're doing their research so that, obviously it's great if it turns into a research paper, but that it also can lead to a practical and make a practical difference. So that's another area. We've also been working on a number of different partnerships and collaborations using information, as I mentioned, that's basically outside of the medical record information. We have the largest integrated healthcare system in the country, so there is a lot of clinical medical record information. But we wanted to see how do you supplement and add additional information to make our conclusions and our ability to use AI more effective. So that involves things like wearables, as I mentioned, things like surveys and other types of data that you can kind of integrate together with that. And so that's been another area. And then we've been looking at how do you integrate with different disease areas. So there are a number of disease areas where we've established a veteran engagement board where we get feedback from veterans about what are particular areas that are of interest to them, whether it be, and then we will work with those different types of experts, in the VIA to make sure that there's AI that can help in those areas, whether it be, oncology, whether it be mental health, whether it be traumatic brain injuries. All those areas have programs going on where potentially AI can help contribute in some ways. And so we're working to form those bridges as well.
Yeah, it sounds like the range of applicability is pretty considerable, especially with just the sheer breadth of conditions you're treating. You mentioned being involved with both looking into mental health and obviously physical health treatment. If you don't mind me backtracking a little bit, something I'm curious about, especially in a bit more depth, is when the COVID-19 pandemic broke out, you're obviously dealing with a novel coronavirus for which there is very little, if not no, extant research or understanding. How did the outbreak of the pandemic reshape the NAII's priorities kind of as it was happening?
Right. And in fact, it did in that first, for the short term, there were kind of immediate needs and desires to focus kind of in that area to try to make a difference as soon as possible. And so that's one. And then just the notion that in doing so, we were always thinking about how can we make sure that we capture these lessons so that we can do things in the future in a way that capture those lessons, right? So things, we learned about new processes, how to do things quicker, work together more efficiently, remotely. Those kinds of things we can now use as we look toward, other conditions that, beyond COVID-19 as well. So I think, in the short term, it reshaped priorities by, we were approached by a number of parts of the organization, around COVID-19 models. We saw that there were a number of different models. We worked toward making them able and able to use AI. That led us, as I said, to the AI to go platform, or framework rather, the AI to go framework, where we can look across different diseases. And so it really helped to shape kind of some of our long-term thinking as well. But some of the things that we did where you have researchers getting input from clinicians and having that iterative feedback is something that we could do, beyond COVID-19. So it shaped the long-term priorities as well.
Absolutely. And it sounds like, in terms of, if you don't mind me asking, just to explain a bit further, what in its essence is the AI to go framework? Because it sounds like that's going to be a jumping off point for a lot of promising research in the future.
Right. Great question. So I think the essence of it is to think about kind of what happened in COVID-19. So at the beginning, essentially no one knows anything, right? So a lot of researchers are trying to create different models, and each of them are, creating different types of predictions. So for example, will this patient survive after 30 days if they have a COVID positive test? What about after 90 days? Some of them use the clinical information. Some of them use, imaging information. And so different researchers have different models, and some of them will then, want to publish that work. And, and then the question is then how does it get used, right? And so what we realized is that it would be useful to get some of that clinician feedback as they're developing the models, and to test it out with clinicians. So essentially they're seeing kind of like a little dashboard that gives them different predictions. So that way they can actually get feedback from clinicians as if it were being utilized, right? And that way the researchers can develop their models and improve them. So for example, one researcher, they were creating mortality models, and they thought it would be used to decide, on different treatments or different therapeutics for the patient. But after getting some physician feedback of looking at all the information presented, they actually ended up finding that it's more useful for other things like palliative care coordination, right? And so then when that, the researcher can optimize and develop it differently given what are the needs at the time, and also what are the type of data that they have access to, and what, their models can do. And so this allows for different researchers who may be developing either different predictors for the same disease or condition, or they could be developing the same model but for different conditions, to have a way to present it to get input, basically in a way that looks to the clinician like they're in a real setting, so that they can give more accurate kinds of inputs. And it allows that model to get that feedback.
Yeah, it sounds like it's fostering a lot of really productive communication and collaboration between researchers and practitioners, like really bridging that gap. And it sounds like the ultimate payoff has been, the end goal of improving patient outcomes, obviously, both in terms of the rapid adjustments you had to make for COVID, but also in terms of really guiding better care for well-known or sort of already treated conditions. And it sounds like the application is there for things ranging from, correct me if I'm off, from things like, kidney disease to even traumatic brain injury.
Right. There are a lot of applications for it. And I would say it's in some sense a complement to some of the work on the AI tech sprint, which, that one is about taking different models, that are applied to data, and then comparing them on different quantitative and mostly quantitative, but also qualitative metrics, right? So accuracy, performance metrics, and other performance metrics that you can compare different solutions. Here, it's looking at some of those other aspects that, the clinician, it may also be how the information is presented. Is the model able to explain why it came up with that kind of a rationale for why it is predicting something? Because a physician may be more likely to adopt the conclusion or the recommendation if it understands why the model came up with that prediction. And so all of those kind of come into this AI to go framework, thinking that, you can take the AI that was developed for research and have it go kind of almost like in a to-go container. It's kind of like encapsulated in a way that's more presentable, rather than, if you're going to get food, if someone just threw a bunch of food at you, what would you do, right? But you're kind of encapsulating to kind of a standardized container that then, people are used to taking that standard container and taking them at home and, and then looking at it. And so that's kind of the thinking there. Whereas in the AI tech sprint, it's more about actual direct metrics, performance metrics and other things that researchers themselves often compare in papers and are very important, but they don't have some of the aspects that maybe a clinician can give that may not be raw numbers that are measurable and like that.
Yeah, it sounds like the ultimate goal is to have AI that is actionable, practically useful. And it sounds like these models, of course, are dynamic things, that they are things that can be potentially refined. And if you have a broader scope of data, that can be used to make the model, even more accurate or sophisticated by the sound of it.
Right, exactly. You saw that with COVID and other conditions where things can change over time, right? What leads to one surge may not be the same population in the next one. There may be different things that you learn over time about the condition as well, because at the beginning you don't have enough power enough patients essentially to learn what the reasoning is, for particular decisions. And after a while, you may have that information, so you can present it. So you learn over time. It's definitely something that is a capability that can enable a learning healthcare system.
Absolutely. And it sounds like it can also be adapted to an evolving public health environment as well, because from my kind of limited understanding, coronaviruses are prone to a certain degree of more rapid mutation than many conditions and than many diseases. And it sounds like these models can be quickly adapted to work with those as well.
So models, the nice thing about AI models is that they can, depending which technology you use, they can sometimes very rapidly learn from new information. So you don't have to train the whole model again. You just add that new information for it to train. In some of the approaches, like the Bayesian approaches, in some other approaches, you have to retrain the whole model, right? And so depending on what you want to do and how often you want to train it, those are some of the things that go into the decisions of what kind of computing you need, what kind of models you want to build, which kind of data you want to use, and how often you want to update it.
Absolutely. And again, it sounds like that foundation has already been established. And even during, what one could say is a bit of a trial by fire period for the entirety of the American healthcare system. But it sounds like, again, there is that really standard and strong foundation you've developed with these models in your approach, which kind of brings me to my next question, which is, now that you have this foundation, now that the NAII has been, running at least for some time, what do you see as your big research priorities going forward?
Right. Good question. So, when we think about what is the work going forward, we look at kind of some of the successes we've had in pioneering some of the new pilots and partnerships and processes and policies, and are looking, how can we develop things further, right? So, you may have seen recently AI, the website AI.gov was launched. It was announced, and the VA and the NI are one of the key partners listed in that effort. And so one of the items that we'd been working on was, thinking about how do you build that AI capacity within the VA, and, potentially, how it's similar and different to what other agencies are doing. So what can we learn by working together? So there are programs, for example, that we have at the VA, such as the Big Data Scientist Training and Enhancement Program, right? So that is a program, the BD STEP program, that enables new researchers to develop their career and work within the VA, and to do that. And then afterwards, some of them stay at the VA. One of them, in fact, is now continued as a member of the National AI Institute over at the VA. So thinking about how do we build capabilities like that is one area. And that kind of all falls also under kind of ideas around workforce development, right? And, there may be people who have degrees in areas, that will be useful here related to AI. And there are a lot of people that may have knowledge and skills that they develop without a particular degree, but would be really great to work in these areas as well. And so we're working on different areas related to workforce certification, where you can understand what kind of knowledge they've gained. And so then you can bridge gaps if there are people who need to do that, through training, or you can find people who, even though they may not have a degree in AI, although there aren't really too many degrees officially in AI, right? But if they have a degree even in a non-technical area, maybe through their own work, they've been able to do a lot of work on AI. We have a number of such people in our institute who've worked and have been able to, with training, develop that. And so we're looking to see how we can collaborate with other offices and other groups to promote that as well. And then finally, building all of that research capacity that is already there at the VA. So the researchers across, the hundreds of medical centers that are actively, working on different research projects. We're working to build that AI community. There's actually this AI VA community and a newsletter that we have that's actually open to people outside the VA as well. And in there, we feature different efforts that are going on in terms of different research areas. And then what we do is we get input from the Veteran Engagement Board, from others across different offices, and find priority areas that then we can further enhance and promote as core areas. And so those are some of the things that we've been working on that I think have a lot of capability to really bring people together. There's a lot of team members that are really making a a big effort here, and we're starting to see some of those results.
Yeah, it sounds like you've really transformed into a knowledge hub of sorts and a place for bringing together all of these really forward-looking and research-intensive parts of both VHA and VA as a whole. That all sounds just incredibly promising. Though I'm afraid our time is about wrapping up, Dr. Alterovitz. But is there anything else you'd like to share with our audience before we conclude?
Well, I think, when you think about artificial intelligence, I think we're really just at the beginning, in some sense. When people, first saw, the airplane of the Wright brothers, it flew for like just all over 10 seconds. People didn't imagine that, that would lead to, eventually, even supersonic flight and so forth, right? So it's almost hard to imagine all the capabilities. On the other hand, I think there's a lot of science fiction out there and a lot of hype as well. And so it's kind of, I think we have to kind of straddle both of those and really make sure that we evaluate what are the good use cases. And so what we've been working on is creating a list of use cases that are really of particular importance to the VA around AI, and ones that we've been then looking to evaluate as a way to see which ones are important ones to focus on and learning from what others are doing as well. So in summary, I think it's a really great time to be in this area. And, you have to just be careful of the hype, but at the same time, sometimes there's options and capabilities and things that you may not realize until you actually get in there. So, people didn't imagine that, an airplane for 10 seconds, could lead to, transcontinental flights. But at the same time, you can, it was a different technology. It was jet engines that really led to that, right? So, there's a lot that's coming ahead. So I'm really excited.
Absolutely. It sounds like a really transformative time to be working in AI. So thank you again so much for coming onto the program.
And thank you very much for having me. Yeah, thank you.
HealthCast is a production of Government CIO Media and Research. For more podcasts, head to governmentciomedia.com/podcasts. HealthCast is produced by Amy Kluber, hosted by Melissa Harris and Adam Patterson. If you liked what you heard, let us know by leaving a review in iTunes or wherever you listen to podcasts. Thanks for listening.